So our next speaker is Max Hamburger. Max is managing partner of Rheumatology Associates of Long Island. He's assistant professor of clinical medicine at State University of New York, Stony Brook, and he's president of the American Society of Clinical Rheumatologists. He's received his MD degree at Albert Einstein. He was an intern and resident at NYU. He was then at the NIH. He's currently president of the New York State Rheumatology Society. He's the board of directors of the Coalition of Rheumatologists and Podiatrists, board of directors, U.S. Rheumatology. And he's going to talk about disease activity measurement and biomarkers in rheumatoid arthritis. Max.
David, thank you very much for inviting me to speak here today. So, I've addressed this meeting several times in the past about disease activity measurement and treating rheumatoid arthritis to target. We've been in the kind of measurement age and the treat to target age over the past 5 to 7 years. And so this is a chance to catch up with where we are and some of the new developments in the area of biomarkers. I can tell you at the outset that I am not going to tell you about the biomarker because we don't have the biomarker yet. We do not have our hemoglobin A1C. We do not have our PT or INR. But we have a lot of fascinating markers that are teaching us about the disease. And so I think it's useful to see the spectrum and then consider where this data may be going. And I'll try and give you a little bit of sense of my own experience with some of this. So some of these slides, all of these slides are in your handout. They're not necessarily in the order that I'm going to present them. So this is kind of hide and surprise. You have to pay attention and you can't just look at your binder. And I've changed the order here and there. So put your binders aside. I'm also not going to go through some of these slides in any detail because you've seen much of this before. Joseph Smolin and his International Task Force on Treating RA to Target published their findings about 3 years and change ago, and we've heard this many, many times. You've seen these overarching principles. I think we all accept the rationale for treating rheumatoid arthritis to target. If we're going to try and use highly complex medications that may have significant potential benefit but also significant cost and complexity, we need to have a target. We cannot simply put a patient on a drug and park them there without seeing did we get them where we wanted them to be. I think that we very much these days focus on disease state rather than just change. The cliche, it's good to feel better, but it's best to feel good. Again, is a statement that I heard first in these halls a number of years ago, I think by Ian McGinnis. And so we have very much changed our focus, I think, as a subspecialty in RA. So the question is, how do we find our way to a target? The International Task Force published 10 recommendations. You have these. Again, I'm not going to read through this. There is an indication to use measurements, look at structural changes, measures of disease activity. So the question of measurement is very much in front of us. And some of us who are old enough have been listening to Ted Pincus and Jack Cush and Marty Bergman and Yusuf Yazigi for years and years. And I think that nowadays rheumatologists very much have moved on to doing some types of measures. So the question is, are these measures working for us, or do we need other ways of assessing RA? I think that most of us probably accept the idea that the target is remission. We're not talking about cure yet, so the target is remission. If the patient has significant enough comorbidity or length of disease, then we may accept a target of low disease activity, and these are well defined in a variety of ways. The idea of accepting moderate or high disease activity is not acceptable anymore. And so what does that mean? Well, it means, amongst other things, a patient could have achieved an ACR 70, which would be an awfully good outcome for a clinical trial.